Mm. Good morning, everyone. My name is
Morning.
Luis, and good morning. I'm the DURB board manager, and it looks like we now have a quorum. And so I will read the opening slide and turn the time over to Dr. Weinstein. If you are dialing in via telephone, Google Meet has muted you. If you need to speak to the group, please press *6 on your phone to unmute and mute. We kindly ask that only those who are speaking to the group unmute their devices via Google Meet. DOR board members, reserve questions until the end of presentations or ask in the Google Meet chat. For public comment, if you would like to provide public comment, a conflict of interest form must be on file. Please send an email to medicatepharmacy@utah.gov. And we ask that you can please send this form a week after the agenda is posted, which the agenda is usually posted 2 weeks before the meeting. Attendees that are not members of the DUR board, please enter your contact information in the Google Meet chat or send an email to medicatepharmacy@utah.gov. Please use the chat on the right if needed, and please provide normative feedback after the meeting to help us improve our process moving forward. Thank you. And Dr. Weinstein, I turn the time over to you.
Good morning, everyone. I apologize for my voice this morning. Just getting over one of the things that's going around. I'd like to call the meeting to order and also just check, Luis, if we have any new introductions for today.
Oh, we don't have those for today. I am excited though because we will have a new physician and a new pharmacist and a new consumer representative for the next meeting, and so we'll do introductions then.
Wonderful, thank you. Okay, first order of business to review, approve the minutes from our February meeting. Hope you've all had an opportunity to review any suggested edits or corrections that need to be made. Hearing, seeing none, I'd ask for a motion to approve the February minutes.
I'll make the motion.
Thank you. Do we have a second?
I'll second.
Thank you. All in favor? Aye.
Aye. Aye.
Thank you. Looks like back to you, Luis, if there's any housekeeping before we get on to the next item.
Yes, thank you, Dr. Weinstein. So I did mention that we will be having the introductions for the new board members in April. And in terms of the prior authorization update, so all of the prior authorization forms reviewed at the February DUR board meeting have been posted, except for Encelto, which will be posted by April 1st, 2026.
Wonderful. Thank you for that update. And I think we have next P&T committee update.
Good morning, everyone. The P&T committee has met in February to review the GLP-1 use for weight management. The P&T committee recommended to have a class of GLP-1 for weight loss on the PDL. However, the funded for the pilot for weight loss is ended in June 30th of 2026. And we has not yet received any notifications that the fund is extended. We are continue to monitor if will be able to going on to cover the GLP-1 for weight loss. If so, it will be added to the PDL. If not, then we probably won't do so. Thank you.
Okay, then if I understand correctly, we'd be prepared if the funding comes through.
Mm-hmm. Yes.
Okay, thank you for all that work. I know this is a huge topic and timely and very important. And we have our next presenter to go over this. We've got a few things on the discussion today. Thank you. I'll pass it to you,
Okay,
Monet.
awesome. Okay, great.
Thank you.
Good morning, everyone. Happy Thursday. Today, we will be reviewing select evidence on the long-term benefits of glucagon-like peptide 1 receptor agonists, abbreviated GLP-1RAs, that are approved for weight management, as well as what information guidelines have for approaches to help maintain weight loss after discontinuing long-term GLP-1RA therapy. Obesity affects approximately 40% of U.S. adults and 21% of the U.S. pediatric population. Obesity is a long-term health condition of excess adiposity that increases the risk and progression of obesity-related complications and diseases, abbreviated ORCDs, including type 2 diabetes, obstructive sleep apnea or OSA, and fatty liver disease, among many others, as listed in the table. In those with obesity, weight loss of 5% to 7% of body weight has been shown to improve glycemic control, blood pressure, and lipid parameters, whereas greater and sustained weight loss exceeding 10% can confer additional disease-modifying effects, potential reversal of type 2 diabetes in select patients, and possible improvements in long-term cardiovascular outcomes and mortality. Although lifestyle modifications are a cornerstone of treatment, significant weight loss with lifestyle modifications alone is often difficult to achieve and sustain for most patients. Therefore, the addition of pharmacotherapy may be necessary, as it can produce greater and more sustained weight loss compared with lifestyle modifications alone. There are 3 GLP-1RA active ingredients that are approved for chronic weight management: liraglutide as Saxenda, semaglutide as Wegovy, and tirzepatide as Zepbound. These agents are approved for weight reduction and maintenance in adults with obesity or with overweight, plus at least one obesity-related condition. Liraglutide and subcutaneous semaglutide are also approved for adolescents with obesity. Semaglutide as Wegovy and tirzepatide as Zepbound have additional approved indications for specific ORCDs in adults with obesity. Semaglutide is approved for risk reduction of major adverse cardiovascular events, or MACE, and for metabolic dysfunction-associated steatohepatitis. Tirzepatide is approved for the treatment of moderate to severe OSA. For each indication, these medications are approved as adjunctive therapy to lifestyle modifications, including a reduced calorie diet and increased physical activity, and they are established for chronic therapy for each indication. Notably, across pivotal phase 3 trials of the reviewed GLP-1RAs, evidence of benefit for weight management in labeled ORCDs was typically assessed after extended treatment durations, with primary outcomes typically assessed after 56 to 72 weeks on treatment. Prior to their approvals for weight management, liraglutide, semaglutide, and tirzepatide had already been approved for the treatment of type 2 diabetes under different brand names shown in the box on the right. Notably, the maintenance doses of liraglutide and semaglutide are established for weight management, shown on the left of the slide, are higher than the doses used for glycemic management, shown on the right. The recommended maintenance dose range for tirzepatide is the same across formulations and indications. This slide summarizes findings from 3 recent Cochrane systematic reviews and meta-analysis, or SRMAs, of randomized control trials, or RCTs. Meta-analysis outcomes were assessed at medium-term follow-up of approximately 6 to 18 months or long-term follow-up of 2 years or longer. This slide focuses on the long-term findings, although the direction and significance of the effect estimates were consistent at the medium-term follow-up. Meta-analysis findings for long-term use of liraglutide, semaglutide, and tirzepatide showed significantly higher proportions of patients achieving greater than 5% or greater than 10% weight reduction from baseline compared to placebo. Additionally, meta-analysis estimates showed significant improvements compared to placebo in continuous weight-based outcomes. Beyond weight reduction, meta-analysis were conducted for MACE and mortality outcomes using study data from the general adult population with obesity, with or without ORCDs, including diabetes. Meta-analysis estimates for semaglutide also showed significant relative risk reductions in MACE and mortality at long-term follow-up compared to placebo. However, the corresponding absolute risk differences were small and were not considered clinically significant. While tirzepatide and liraglutide did not appear to significantly reduce MACE or mortality risk at long-term follow-up, meta-analysis point estimates trended toward a benefit. This slide lists ORCDs that we are aware of in which there is positive evidence of benefits with the reviewed agents from completed phase 2 or 3 trials. This includes benefits in prediabetes, osteoarthritis knee pain, and heart failure, among others. Now I will discuss the topic of discontinuing GLP-1 RA therapy after patients have achieved clinically meaningful weight loss but are unable or unwilling to continue GLP-1 RA weight management formulations at the labeled full dose or altogether. Long-term continuation of GLP-1 RA therapy may be limited by several factors, including patient preferences, medication cost, or insurance coverage, potentially leading to treatment discontinuation even among patients who've responded to therapy. Discontinuation of GLP-1 RA therapy is common in real-world practice, with approximately 20 to 50% of patients discontinuing GLP-1 RA therapy within the first year of treatment. Some authors have further investigated reasons for discontinuing semaglutide or tirzepatide within the first year of treatment in the real world and found that the most common reason was halted financial access to the medication due to cost burden or insurance coverage issues. Meta-analysis effect estimates from an SRMA of RCTs showed that complete discontinuation of liraglutide, semaglutide, or tirzepatide used at the weight loss doses after initial treatment period was associated with significant weight regain. Patients who discontinued liraglutide regained a mean of 2.2 kilograms after 12 to 26 weeks of discontinuation. Those who discontinued semaglutide or tirzepatide regained a mean of 9.69 kilograms after 48 to 52 weeks of discontinuation. Notably, these findings were observed despite continued counseling on lifestyle modifications in most included trials. In the randomized withdrawal trial STEP 4 and SURMOUNT 4, enrolled participants were initially treated with semaglutide or tirzepatide and then were randomized either to continue GLP-1 RA therapy or to discontinue the therapy by switching to placebo. Included participants in each trial also received counseling on lifestyle modifications throughout the entire study duration, including during the randomized withdrawal phase in both the active treatment and placebo withdrawal arms. Mean weight regain during the discontinuation phase was 6.1 kilograms after 48 weeks of semaglutide discontinuation and 11.1 kilograms after 52 weeks of tirzepatide discontinuation. Although treatment discontinuation was associated with an average trend of progressive weight regain and significantly more regain compared to continuing active treatment in these trials, many participants in the withdrawal arms were still able to maintain meaningful weight loss goals relative to their pre-treatment baseline before starting tirzepatide or semaglutide. Compared to the initial baseline prior to GLP-1 RA treatment, on average, the GLP-1 RA discontinuation arms regained about half of the initial weight loss during treatment. We reviewed recently published US-based or international guidelines or expert consensus statements for recommendations or guidance regarding approaches for maintaining weight loss after discontinuing GLP-1 RA therapy or anti-obesity medications in general in patients with obesity or overweight with or without ORCDs who have responded to chronic treatment. Across reviewed obesity guidelines in the general adult population, long-term pharmacotherapy is recommended as an adjunct to lifestyle modifications for patients with obesity or overweight, particularly when ORCDs are present. For adults with type 2 diabetes and overweight or obesity, the 2026 American Diabetes Association guideline recommends that pharmacotherapy indicated for chronic weight management be continued even after attainment of weight loss goals. Multiple guidelines recognize that discontinuation of pharmacotherapy can lead to weight regain and potential reversal of improvements in ORCDs. Therefore, the 2025 Department of Veterans Affairs Department of Defense guideline weekly recommends against discontinuing anti-obesity medications while considering patient preferences. When discontinuation of GLP-1RA therapy is unavoidable, expert consensus recommends close monitoring for weight regain and ensuring alternative measures for weight maintenance are in place. These include continuing lifestyle modifications, considering a calorie-controlled protein-rich diet and or partial meal replacements, referring to a registered dietitian and providing multidisciplinary behavioral support when available, and participating in an individualized exercise program. Aside from this, because there is limited evidence, guidelines do not provide formal recommendations regarding best approaches to step down GLP-1RA therapies in patients who must discontinue the labeled recommended full dose for weight loss. Guidelines highlight that an individualized long-term weight management strategy should be used after weight loss goals are achieved, recognizing that weight maintenance over the long term may require a different therapeutic approach than that used for initial weight reduction or maintenance. In general, strategies may include continuing drug therapy at the lowest effective dose for the patient for weight maintenance, using medication intermittently or completely discontinuing treatment while continuing lifestyle modifications, and closely monitoring for weight changes. We infer that the lowest effective dose could include using lower doses than the labeled maintenance dose, provided it is effective for the patient, especially if it offers more benefits long-term versus complete discontinuation of the drug. To potentially address financial barriers, the 2025 American Association of Clinical Endocrinology consensus statement suggests patients could switch to a lower-cost anti-obesity medication for weight maintenance after initial chronic treatment with semaglutide or tirzepatide. Currently, there is a paucity of high-quality evidence to guide the use of specific strategies, including use of lower GLP-1RA maintenance doses or extended dosing intervals of GLP-1RAs to mitigate weight regain after patients have achieved clinically meaningful weight loss, but are unable or unwilling to continue GLP-1RA weight management formulations at the labeled full dose or altogether. Available evidence supporting dose reduction or extended dosing intervals of GLP-1RAs or switching to lower-cost anti-obesity medications is limited. Based on an exploratory narrow search, literature search for primary studies published in 2025 onward, we identified few observational studies, only one each, for using lower than recommended maintenance doses of semaglutide or for switching to alternative lower-cost anti-obesity medications after discontinuing GLP-1RA therapy. Additionally, using lower semaglutide doses has been based on data extrapolation from a phase 2 dose-finding study of daily semaglutide administered at lower total weekly doses. For using extended dosing intervals of GLP-1RAs, there is available evidence from a case series of 2 patients and a pharmacokinetic pharmacodynamic model. Overall, the limited evidence suggests that these strategies may help maintain weight in some patients, but confirmation from controlled trials would be helpful, especially to make formal recommendations. The 2025 Department of Veterans Affairs Department of Defense guidelines position was neither for or against reducing the dose or decreasing the administration frequency of anti-obesity medications to support weight maintenance in patients who have met their weight loss goals due to insufficient evidence. In conclusion, if GLP-1RA therapy is discontinued, a multidisciplinary individualized approach should be used to help patients maintain their weight loss. Although counseling on lifestyle modifications alone may be insufficient to fully prevent rebound weight gain in a considerable proportion of patients, continual adherence to such practices can help support weight maintenance following GLP-1RA discontinuation. Therefore, it is important to establish sustainable nutrition and lifestyle practices early prior to and during GLP-1RA therapy. Accordingly, providers should ensure that a patient-specific transition plan is developed before stopping GLP-1 RA therapy. This plan may include setting realistic weight maintenance goals, establishing regular follow-up appointments with a multidisciplinary team, promoting ongoing participation in structured exercise and nutrition programs, and regularly self-monitoring weight to detect early signs of weight regain. This concludes the presentation. Thank you so much for your time and attention.
Thank you so much. It's clearly an important topic right now, and I wonder if the board members have any comments or questions. It's an excellent summary, and I appreciate the highlighting of lack of evidence for discontinuing treatment. I think we've all observed that there is a huge direct-to-consumer aspect to this therapy as well, where we have patients who are, accessing these medications in the absence of comprehensive lifestyle counseling and support. And I don't know how much that affects our decision making in terms of what we do. It really depends on funding, it seems, but I think this is clearly going to be an ongoing issue into the long-term future. So thank you so much for that comprehensive report. Are there any other comments or questions or committee discussion we need to have at this time?
Yeah, I just wanted to mention that Ewan and I attended the ADERS conference recently for Medicaid for states, and we learned that many of the states that had coverage for GLP-1s for weight loss are kind of, due to funding, having to revert and not able to cover them. So it's interesting.
Mm-hmm. Well, I guess the consideration for, the bigger administrative perspective is, is this preventative, ultimately cost preventive. Dr. Britton, you have a hand up?
Yeah, I was just going to mention that it's difficult also because the weight loss benefit is just on the fee-for-service side, and the ACOs do not have access to that because of the funding. So members that go from fee-for-service to the ACOs end up being discontinued as well.
Mm-hmm.
And one of the things that really hasn't been brought up necessarily is a comprehensive behavioral modification program. It is super hard to get people to adhere to that as well as the GLP-1s.
Mm-hmm.
I do think that ideally that would be the best way to maintain adherence and to get sustained results, but it's difficult.
Thank you for that. For sure. Do we have any other comments from the board or questions? So right now this is informational, as I understand, and we'll wait to see if funding comes through, but it sounds like it may not. And we'll address any related issues as they arise for this board. I think next up we have a public comment. I'm not sure who's on today for which topics, Luis?
Yes, Dr. Weinstein. So our public comment space is empty.
Okay.
So we'll move on with the prior authorization reviews.
Thank you so much. Let's keep moving. Thank you. I think it's Dr. Wan.
Good morning, everyone. Let's see. Okay, so I have a Kisumla. The first criteria is a patient 18 years of age or older, Does the patient have diagnosis of Alzheimer's disease with mild dementia or mild cognitive impairments as evidenced by the following within the past 6 months? The mini mental state examination MMSE score of greater or equal to 21 and less than or equal to 30, or the clinical dementia rating global score, CDR-GS of 0.5 or 1, or the Montreal Cognitive Assessment MOCA score of 16 to 25, and then of progressive change in memory function over the past 6 months. Is the medication being prescribed by a board-certified neurologist, psychiatrist, neuropsychiatrist, or geriatrician? Does the request include documentation of a baseline brain magnetic resonance imaging MRI within the past year without evidence of cerebral amyloid angiopathy, such as more than 4 microhemorrhages, superficial siderosis, white matter disease, vasogenic edema, and etc.? This request include documentation showing presence of amyloid beta plaques as determined by positron emission tomography, PET, or lumbar puncture. Does the patient have a documented 3-month trial and failure of the following? Cholinesterase inhibitors, such as donepezil, rivastigmine, and memantine. And does the provider attest the patient will not be taking any anticoagulant concurrently with Consilna or have a history of clotting disorder? Does the provider attest to test for apolipoprotein E echelon 4 status and counsel on those with homozygotes on higher incidence of developing amyloid-related imaging abnormalities or ARIA prior to the initiation of therapy? And then we ask that they provide genetic test results. Does the provider attest that the use follows FDA-approved label dosing and monitoring? Does the provider attest to evaluate pre-existing ARIA and before the 2nd, 3rd, 4th, and 7th infusions via MRI? And if radiographic observed ARIA occurs, treatment recommendations based on the prescribing information would be followed. And with the reauthorization criteria, does the patient continue to meet all initial requirements for initial approval? The patient shows a positive clinical response to therapy as demonstrated by no increase in amyloid plaque or radiographic stabilizations as compared to baseline. Has chart notes been submitted documenting the adherence to MRI monitoring, so prior to the 2nd, 3rd, 4th, and 7th infusions, and any specific findings related to ARIA? The patient has not progressed to moderate or severe dementia caused by Alzheimer's disease as shown by an updated score above, so the CDR Global Scale score, MOCA score, and MMSE score. And then we have noted below the black box warnings. Is there any questions or concerns? Yes, Dr. Siegfried.
Regarding use of Namenda or memantine, it is not FDA approved for mild cognitive impairment or mild dementia. So were the patients actually treated with Namenda prior to use of this antibody in studies?
I am not sure on that one. I will have to check. We'll make a note of that. Let's see.
Thank you for that, Dr. Siegfried. I think it would be hard to require step therapy if that's generally not approved specifically. And I don't know the answer to that question, but I think we should see if we can get clarification on that. Excuse me. Then depending on which way that answers out, would you have a recommendation or thought about how we might modify the PA?
Well, unless it was used off-label in the clinical trials, requiring its use off-label prior to access of this therapy would be burdensome and likely not, it's not really been shown to be effective in MCI or mild dementia in clinical trials. So it, really would not need to be there as step therapy unless it had been used in the clinical trials for approval of this antibody.
Thank you for the recommendation, Dr. Siegfried. Yeah, I was looking at the prescribing information. It looks like the patients in the clinical trials were enrolled with or without any concurrent therapy with this medication. So we can go ahead and remove it if everyone's also okay with it. Dr. Britton.
I think I'd love to see more information. This is an infusion, is that right?
Correct.
Yeah. I think anytime that you're going to a more advanced therapy, if you will, you would like to see some less invasive, safer medication. So what are the possible side effects of this?
Well, Namenda is actually fairly well tolerated and is actually, it does come also as a combination product with donepezil. But in general, it's not a first-line treatment for mild cognitive impairment or mild dementia. But again, going, back to, looking at the studies that have been done, it may have been used just to also ensure that the individuals enrolled in the studies, had exhausted all less invasive treatments.
Yeah, I think what I'm seeing is it can cause that swelling, temporary swelling in areas of the brain, small spots of bleeding. These Alzheimer's drugs, a lot of them, potential serious side effects with limited efficacy. What was the efficacy of this drug? I'm sorry, I'll get on camera. I was eating.
Thank you.
Sorry, I
Do
don't
we
have.
we have an answer to that? Excuse me.
Sorry, I'm looking at the primary endpoints real quick. So the primary endpoint that they've looked at was integrated Alzheimer's disease rating scale. So the ADRS score from baseline to 76 weeks. Looks like the combined population, it's a treatment difference of 2.92. Apologies, I did not have all those information ready.
It's okay. I think this is, the way that, excuse me, the way the PA is set up is clearly narrowly restricted in terms of their folks having to follow, a fair number of prerequisites. But I think it would be, maybe the board would like to just have a little bit more of a summary as to the drug itself, and if there are, clinical trials like where this might fit and what we do about the step therapy, if there is no step therapy that we can require to make sure that we've got this positioned properly. I believe we do, but I feel like, the board may want some more context. Does that capture where we're at?
Totally. Yeah, we can bring this back. And Louise, will we send it out again and present it for a future meeting?
Yes, I agree. We can definitely bring it back in pertaining to criteria number 6. If there's any updates based on the information that we found. And again, this criteria we came up with over a year ago, and there was a different author for this PA. And so, sorry, Iris, that you're getting all these questions.
That's totally good.
Well, I think we can probably get it taken care of with just a little bit more context information. And if we need to make these minor edits to the form, I think we should be able to review that and make a decision at its next presentation. It is intensive therapy, clearly, a different category for what, most patients might be treated with in general practice. So we will want the restrictions and to make sure we've got the lanes set up properly. So appreciate all that. Any other comments or suggestions from the board on this so they can take that forward?
I was just
Dr.
going to mention until we get that, I mean, I'm sure if you get requests, you can review it for medical necessity, right? According to the criteria that you found, that would indicate medical necessity, right?
That's right. Yeah, we still have an avenue for coverage.
Okay. Thank you.
Okay, we'll pend the committee action to our next review of this, and I think you're up on the Pompe disease next. Louise.
Get that up. All right, so here's our next PA, Pompe disease. In parentheses, we have the enzyme replacement therapies currently available, which is lumizyme, nexviazyme, Upfold, which goes together with Pombiliti. So just as a background, Pompe disease is a lysosomal storage disease where the enzyme alpha glucosidase there's a deficiency there, and it is a genetic disorder. And so with the decrease or deficiency in this alpha glucosidase enzyme, it leads to accumulation of glycogen within the lysosome in all tissues, which leads to tissue destruction, myopathy, cardiomyopathy. And so there's also skeletal muscle issues and weakness in these patients. And so the treatment is enzyme replacement. And so here's our criteria. All the following criteria must be met. Does the patient have a diagnosis of Pompe disease as determined by assay testing or gene sequencing? Is the medication being prescribed by or in consultation with a geneticist, neurologist, pulmonologist, or metabolic specialist? Has the provider obtained a baseline forced vital capacity and 6-minute walk test result? And so we have the A for the result. And then for the 6-minute walk test, if available, or if able, sorry, because this disease can affect infants. There is an infantile onset and also a late onset, which the late onset can present itself at any time in a person's lifetime that has the disease. And then we have additional criteria for Nexviazyme, which is indicated, FDA indicated for late onset, for the late onset form. And so there's just age criteria there. Is a patient 1 year of age or older? And then will the medication be used to treat late onset Pompe disease? And then additional criteria for Pombiliti and Olpruva, which Pombiliti is the enzyme replacement therapy, and Olpruva should be taken together, and Olpruva is an enzyme stabilizer, and it's oral, where the Pombiliti is IV. And it's also indicated for late onset. Is the patient 18 years of age or older? Does the patient weigh greater than or equal to 40 kilograms? And then will this treatment be used in combination? Will the medications be used to treat late onset Pompe disease? And then is the patient symptomatic, defined as a presence of skeletal or respiratory muscle weakness as determined in clinical examination and or spirometry? And I also learned that for the late onset form, usually the symptoms are more skeletal muscle weakness or respiratory muscle weakness, versus the infantile onset, it's more of the cardiomyopathy component. Has the patient had a 12-month trial in failure of or intolerance to the following? And so here it's kind of like step therapy, asking for Luminzyme and Nexviazyme enzyme replacement before approving for the Pombiliti and Olpruva. And then reauthorization criteria: has the patient experienced an improvement or stabilization in FVC and DURB 6-minute walk test results if the patient is ambulant? Initial authorization is for up to 6 months. Reauthorization is up to a year. And then down here in the notes, we have the black box warnings for these therapies, which it includes reactions to infusions and like anaphylaxis, and then other more serious side effects, which can also involve compromised cardiac or respiratory function. But yeah, that is all that we have for this PA. Any questions? Yes, Dr. Kosinski.
So the drug handout for the drug that goes with the Pompetti, it's Buda. Are those different or the same? Sorry, because that's spelled differently on the prior auth than it is in the drug handout that we got.
Let's see here. Upfolda. Okay, you're right. Thank you.
That's in a couple places, I think.
Yeah, it is.
Yeah.
Thank you for that. I appreciate it.
It's a lot to keep track of.
Definitely.
And they're so hard to spell, so I get it.
No, but I appreciate your eyes. Thank you so much for pointing that out.
Thank you. Was there another spot up above? Does anybody have any substantive concerns or questions with this? And I think this might be, relatively low demand, but like the other genetic and enzyme therapies we've been seeing, making these available where they're appropriate.
I was thinking, since the infantile onset Pompe disease form involves a lot of cardiomyopathy and heart failure, predicting us the initial symptoms. Perhaps include a cardiologist up here, a number 2.
I don't think it would hurt. Does the board have any objection?
I think if it's an right, not just an and, I think that might be good because people tend to work, I know our geneticists work with the different specialists, so I would do an or, not an and, if that sounds okay.
I'm sorry, I didn't catch the specific suggestion. Did you want to put something else in?
It looks like that it's or up there. Sorry, it's hard to see on my screen exactly. So
Yes,
so they're ors. I think ors are great, but
it is an or. Yes.
Give me an or, not an and.
Yeah, we have an or.
I mean, I don't know if there are any other pediatric subspecialists that, we would need to name here. I was trying to think through, but it's been a while since I've, participated in the care of any very young patient with Pompe. But we've got a geneticist, neurologist, pulmonologist, cardiologist, or metabolic specialist. And that's a consultation, right? So I think that's pretty broad. If we find out we've missed something, we can always add it in.
I agree.
With that edit, are there any other concerns, questions, or recommendations from the board?
Do we need to move to approve?
Thank you. And can we have a second?
I'll second.
Thank you. All in favor of approval for this PA? Aye.
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 Thank you. And next meeting in April 9th, I think we have some other material up on the agenda for the GLP-1 receptor agonists, and we can see if we're being funded at that point or not. I don't know when we might get word about that. If there are no other items for the board consideration today, Luis, are we concluded? Do we have anything else?
No, that is all for today. Thank you so much.
Okay, thank you. I think we're giving you a little time back. We'll take a motion to adjourn.
So move.
And
Second.
second. And I appreciate you bearing with me today. Thank you. You all have a wonderful day and a good month, and we'll see you in April. Thank you for your participation in the board.
Thank you.
Thanks,
Thank
everybody.
you.
Bye.
Aye.